continuing on looking at motion as our central point in our network of meaning or in our semantic network with respect to understanding anatomy, we're looking at hip abduction or hip abduction. So as is consistent, our objectives are to have a discussion of what hip abduction is with respect to planes and axes, very general discussion of the muscles that perform this motion, a general discussion of the neurovascular bundle, and a general discussion of areas to assess and treat should hip abduction issues be suspected or reported. So our quick review of planes: the sagittal plane is a 50% cut of the body left to right. The horizontal or transverse plane is a 50% cut of the body top to bottom. The frontal or coronal plane is a 50% cut of the body back to front. With your axes being perpendicular to planes, the sagittal plane has a horizontal or transverse axis. The horizontal or transverse plane has a vertical axis, and the frontal plane or the coronal plane has a 50%, frontal or coronal plane has a posterior to anterior axis or an anterior to posterior axis, depending on your preference for terms. With respect to hip abduction or hip abduction, it is going to occur in the frontal or coronal plane about the hypothetical anterior to posterior axis. This is not how it actually works, because the hip joint itself, or the coxofemoral joint, is a ball and socket joint which is multi-axial or multiplanar. Therefore, the axis is hypothetical and determined by the muscles themselves. So it is going to be movement away from the midline of the body, right? So the thigh is going to move away from the torso with respect to the midline of the body in the anatomical position. So this is going to occur in the frontal or coronal plane, moving away from the midline of the body about a hypothetical anterior to posterior axis, which isn't really how it works on account of the fact that the coxofemoral joint is multi-axial and multiplanar. So the muscles that we're going to be considering here with respect to the muscles that perform this motion, you're looking at gluteus maximus, minimus, and medius. Regardless of fibers, they're all going to contribute to hip abduction. You're looking at the tensor fasciae lata, the piriformis, and the obturator internus. Those are the muscles that are going to perform this action. Therefore, with respect to where you're likely to treat if this movement is not working as it should, or this movement there's a preference for this motion rather. So the hip likes to be abducted and does not like to adduct or move towards the midline of the body, which you're almost never going to see. But if there is some issue with it, then, or with this motion, then with respect to the muscles, you're basically going to have to run around the trochanter. So on the low posterior side, you're thinking about the gluteus maximus, to some degree the obturator internus, not absolutely, but sort of, the piriformis. Then as you come up around the trochanter, you're thinking about the TFL, the glute minimus, and the glute medius. So you just kind of run around the trochanter with respect to the muscles. Very similar thing with respect to the neurovascular bundle, but not exactly. The neurovascular bundle, you're very much thinking about the lumbosacral plexus, a little bit more sacral plexus. You're thinking about the superior inferior gluteal nerves. You're thinking about direct branches to the piriformis and the obturator internus. From the sacral plexus, you're thinking about the superior inferior gluteal artery. To some degree, you may be thinking about some stuff directly out of the internal iliac. And so you're thinking about just kind of running around that trochanter. You don't necessarily have to go down the thigh, the posterior aspect of the thigh, much with respect to blood supply or nerve supply in this case. You can kind of stay around the trochanter. You may have to look at the inguinal region. You may have to look at the anterior soft tissue of the thigh with respect to the blood supply to the TFL, as well as the blood supply to the anterior portion of the glute min and glute med, but maybe not so much. You can pretty much just run around the greater trochanter with respect to hip abduction. As far as the neurovascular bundle is concerned, again, keeping in mind that we treat best based on motion assessment findings, either in large motions identifying smaller problems or where the actual problem is going to be living, as well as soft tissue yield to pressure. So you squish a soft tissue, everything either squishes the same, which is fine, or some things squish fine and one thing does not squish particularly well. The area of higher tone is the area that doesn't squish as well. That's what you treat. So even though the neurovascular bundle and the muscular regions are smaller with respect to abduction and where you would assess and treat, you still do your best when you're basing your treatment on the movement findings as opposed to chasing the neurovascular bundle. As we've noted already in this discussion, your areas of consideration for assessment and treatment, the lumbar column, so the neurovascular bundle, the inguinal region with respect to the neurovascular bundle, more vascular, especially with TFL and the anterior fibers of gluten and glutamine, the posterior soft tissues of the pelvis, the muscles and the neurovascular bundle. So as I said, you just kind of run around the trochanter, and the superior region of the trochanter. So as I know, you just kind of run around the trochanter and to the inguinal region, the anterior soft tissues of the thigh, and you'll probably have gotten what you need to get with respect to hip abduction. Known fractures or tears or red flags, you don't treat them. You can treat the patient, but you don't treat the fracture or the tear. Suspected fractures or tears, you refer out for further evaluation, differential diagnosis. If no fracture or tear is found, then you are likely safe to treat. You still want to be conservative, but that's your red flags and contraindications there. If, again, anytime you're dealing with something that would relate to the lumbar plexus, rebound tenderness on the abdomen, which means you push on the abdomen, there's no pain, you let go, and there's pain when you let go, that's a visceral pathology. Until proven otherwise, you refer that out immediately. That's a red flag. So that's not necessarily going to be in your consideration here, but if it happens to be part of your total finding, that's something that you refer out.